I'd like to share with you our experiences in terms of revisiting a concept that may be dear to some of us and may trigger a lot of anxiety in others, brachytherapy. These are my disclosures. I am a speaker for GT Medical. This is the outline of today's talk. I'm going to give you a little bit of a perspective in terms of brachytherapy and glioblastoma. Share with you some of our experiences in terms of gammatiles in recurrent glioblastomas. And I'm actually going to touch base a little bit about how this technology can actually advance our care of newly diagnosed glioblastomas and share with you a clinical trial that I hope many of you will participate in. And then we'll talk a little bit about brain metastasis. And here, I know that brain metastasis is predominantly treated with radiosurgery, and it works quite well. But there are unique circumstances I'd like to share with you where Gammatile may be a consideration, or brachytherapy in general might be a consideration. Glioblastoma requires no introduction to this audience. I'll just point out two interesting things. Several of influential political leaders in our country has been afflicted and died of this disease. There's a lot of interesting what ifs you could play. What if Senator Kennedy lived and the Democrats did not lose their supermajority? What if now President Biden's son did not die and back then Vice President Biden entered the race in 2016? It's possible to argue that this is a disease that has fundamentally influenced the political trajectory of this United States. The other thing I want to highlight is that local control remains a major issue. I show this paper because it's my firm belief we need to know where we came from. How do we know that there are tumors beyond what we could see? Well, this is Pat Cowley's work in early days where he biopsied beyond tumors. These figures are dear to me. It's a bit of a historical, tremendous historical value. From these papers came out with this notion that there are tumors 2-3 centimeters away from the tumor. And this is why we define our radiation therapy the way we do today. What's really important though, is if you look at the modern series, up to 80% of glioblastomas recur locally. And that's sobering, right? We do a good surgery and 80% of the tumor comes right back to where we did our surgery. Now, there are data suggesting that up to 80%. Now, when we do surgeries, we usually wait 4 to 6 weeks before radiation and chemotherapy is given because we're all paranoid about wound breakdowns. And it's important to know that based upon analysis done by UCSF and other groups, 50 to 70% of the patients will actually have growth in that resection cavity. Some of these contrast enhancements are hard to tell if they're actual tumor growth or they're small infarct or inflammation, but the UCSF group actually looked at these contrast enhancing areas with spectroscopy. And what came back is consistent with tumor growth. And so they're estimating that 70% of the patients the tumors grow while we're waiting. The other very interesting study is, or the aspect of this study is, of those patients whose tumor grew back locally, their prognosis is a lot worse. You can see that in this study, in the UCSF study, and you can see that in many other studies. So one of the questions we've asked early in the 1980s and 90s is, well, is it possible for us to shift the curve? Brachytherapy will not be the cure. We know there are tumors 3 centimeters away where brachytherapy will not touch it. But can we shift the curve? I'm of the opinion that we can. Here's an example of my own patient. These two patients both had glioblastoma and they presented 1 week apart to my clinic. And, of course, one's on the left, one's on the right. I thought I did a reasonable resection for both of them. One of the patients consented to Gammatile, one of the forms of brachytherapy. At 1 month follow-up, the scan looks pretty decent. This other patient didn't do so well. Local recurrence is a big deal, and all of us know that. This is probably the most dramatic example I could think of. Of course, this patient ultimately died about, I think, 12 months later, but we did give this patient 12 months of time, and it is meaningful for many patients. Brachytherapy, all of you know what this is. We implant radioactive seeds in the area. It allows for highly conformal radiation delivery. It allows radiation dose beyond that which can be delivered through external beam. Here we're talking about 120 to 150 grays. If you try to deliver that through external beam, you kill the patient. And it forces immediate initiation of therapy, right? In that spirit of, can we convert that curve of tumors that came back locally to eventually it came back distantly, right? Now, many of us were disappointed by these two clinical studies. These were actually two studies that killed brachytherapy for a long time. In this study of 140 patients, glioblastoma patients were randomized to either external beam or brachytherapy. And it was thought that there's no survival benefit. Okay. But in retrospect, as we learn more and more about the tail of patients who survive, right? Look at this is the curve that allowed Timodar to become the standard of care therapy, okay? This is that beautiful Roget study. The median survival there's nothing to write home about, about 2 months. It is this tail of people who lived beyond expectation that convinced the FDA to approve this as the standard of care. Do you see a tail here? Yes, you do. We just didn't appreciate what that meant back then. In this other study of about 200 patients, this is RTOG 8701. By the way, this study did not use chemotherapy at all, right? This would never happen in today's world. In the 8701 study, this is actually BTOG, not them. Anyway, if you look at the survival curve of this 200 patients, do you see a resemblance here? This is of 200 patients. This is of 571 patients. One interpretation is that brachytherapy is actually helpful and we just didn't power it enough. But yet these two studies had led to the demise of brachytherapy. If you look at, this is a SEER database that has data in terms of when we implanted radioactive seeds after surgery. There was a big peak in the 80s and 90s, and then nobody does it anymore because we thought the randomized control study didn't work and therefore it's useless. I would argue that if you revisit the clinical study through the lens of modern randomized control study design, both studies are flawed beyond meaningful interpretation. What we did in the study is we actually looked at these patients who underwent brachytherapy and we controlled for variables that we know influence survival: age, size of tumor, location of tumor. And if you were to correct for all the variables that are available in the database, and granted, not every variable is in the database. We didn't have IDH mutation status, we didn't have KPS, etc. But if you control for all the variables that we know are important, brachytherapy still confers survival benefit. Okay. Now, this is by no means a class 1 evidence, but it's something to think about. So I've been very interested in brachytherapy for a long time. This is kind of my early experience when I was at San Diego. This is in the days of the sort of gamma site or the gliocyte and mammocyte. Okay, so what we ended up doing, because I wanted to improve local control. You know, one of the interesting things about local control is it really affects the patient's psychology. You know, for a patient who had a major surgery and the tumor came back in 3 months in the exact same spot, I will tell you it is demoralizing to the patient. And often that leads to the decision of palliative care in a select set of patients. So if we can buy that time, that can be of benefit to the patient. So anyway, we started using, you know, the gliocytes and and mammocytes. We had a disaster with the gliocyte where someone dropped the vial and contaminated everything. So we shifted to this mammocyte where you could insert a radioactive rod. In any case, what we did was we took the tumor out, inserted the balloon, performed radiation to about centimeter margin. And then the patient underwent standard chemotherapy as Stoop protocol, Timodar radiation. Back then, again, we didn't know about IDH. We didn't know about a lot of the molecular markers. So we just stratified by RPA class. And in every RPA class, the patients who were treated with a combined modality, including brachytherapy, did a lot better than the patients who didn't. Of course, you can argue about selection biases and things like that. But we're not the only one to observe this. There's been 2 or 3 other studies besides ours that show the same pattern. So Gammatiles, why am I so excited about Gammatiles when they came out? After this long history of being interested in brachytherapy. Well, one thing, this is a low dose rate radioactive source, rather than some of the higher dose rates, which can be associated with morbidities. Has a half-life of 9.7 days. And I really like this collagen, embedding the 4 seeds in the collagen matrix, because I use collagen matrix all the time. So this is kind of innate to me. I don't have to learn a new skill set. It delivers 120 to 150 grays to the surface. So this is a very powerful amount of radiation. And it delivers 60 to 80 at 5 millimeter in depth. This is important because, remember, this is not a cure. The way I kind of like to think about Gammatiles and brachytherapies is I think of a football game where you have 30 seconds left, right? You got to throw the touchdown to win the game, but you still need the offensive line to block. So there's enough time for the quarterback to throw that winning touchdown. Your Gammatile is your offensive line. It's not going to win the game, but it will buy you time. Right. And for a lot of things like immunotherapy, where you do need time to work, this may be an opportunity, and there's maybe synergy. The other thing I really liked about Gammatiles is that these collagen matrix dissolve over time. So the resection cavity is stented open. In the old days, when we used to use, before the balloons, we use seeds. One of the problems is the resection cavity collapses, and then the seeds get closer to one another, and now you got excessive dose of radiation that causes problems. So when you have the tiles, the collagen stay in place, keeps the seed from getting closer to one another. You're using a lower dose, or rather low dose rate radiation, right? So those are things that augments the safety, in my mind, that bypasses a lot of the problems that we've seen in the early days. This is a paper that's going to be coming out in Neuro-Oncology. We kind of looked at the experiences of Gammatiles preclinical. So this is before FDA approval. This is done under IRB at the Barrows. Okay. They looked at 28 patients who had recurrent glioblastoma. Okay. 20 of which are first recurrence, 8 are second or more recurrence. And they looked at survival and complications. And what you see, and this is registered with the clinicaltrial.gov. So it's a prospective study. It's harder to manipulate the data with a prospective study, although you'll do it. But this is a very honest study. The median follow-up is about 7 months. There was 1 wound infection. So this is not outrageous. This is not the kind of stuff that we saw in the early days of Glioblastomas, for example. The local control rate is about 50%. Okay? And some of this has to do with making sure this is preclinical, so a lot of the things are not standardized, but still better than the kind of 20% local control we've seen typically. This is plotting out survival after Gammatile placement. And what we've done is some of these patients underwent chemotherapy afterward and others did not. This is a very illustrative case where a patient recurred, underwent resection in Gammatile, and then lived for a significant period of time without chemotherapy. This patient is important to me because it tells me that there are glioblastomas are more focal than diffuse, and that if you can achieve that local control, these patients will benefit. The problem is we don't know who these patients are. If we have a molecular marker for who these patients are, then these will be the patients you want to select them out for aggressive local therapy. This is to illustrate survival before the recurrence and after the recurrence. And the other interesting thing with this curve is that many of the patients suffer recurrence at a certain time, but then with tiles, they actually have lived a significant, they live longer than the time to recurrence, right? So it's not time to give up just at first recurrence. And I know this is the audience knows this. This audience knows this. So Gammatile was approved in 2019, and we prospectively followed. We had a protocol. We prospectively followed the first 22 patients that we treated, and we just published this paper recently because we wanted enough time to follow the patients. So we had a series of 22 patients. The typical male to female ratio, the age, and KPS are typical of patients that you would operate on. And the KPS is selected. If you're a KPS of 60, I'm not going to be operating most of the time, almost all, never. So 81% of the patients presented with neurological symptoms referable to the recurrence. So I don't operate a lot on recurrences. These are patients who are symptomatic, and there are literature suggesting the symptomatic patients are worse than the asymptomatic recurrences. About 60% second recurrence, 36% third recurrence. There were 2 post-operative complications. There's 1 seizure and 1 death. The death came from an unfortunate situation where the patient was on Coumadin prior to surgery. We stopped Coumadin. The patient did well for 3 days after surgery, a good resection, but then the patient developed an ischemic limb requiring reinitiation of anticoagulation. And unfortunately, 48 hours of initiating full anticoagulation, which the vascular surgeon insisted on, otherwise they wouldn't operate to rescue the ischemic limb, the patient suffered a catastrophic hemorrhage. I mean, it was salvageable, but the patient's family at that point felt that it's enough, and so they called it a day. Overall, fairly favorable safety profile from both the previous study and in this study. And I will say that we're working on a multi-institutional experience. We have now almost 70 patients with Gammatiles, and the safety profile is very favorable. And between the 3 studies of almost now 130 patients, we had 2 infections and 1 wound breakdown. The follow-up was 733 days, so enough to know what's happening to the patients. Now, we stratify, all these patients are IDH wild type, okay? So we're not picking out favorable patients. Of the patients who are MGMT promoter methylated, what you will see is of the patients who got treated with Gammatile, we actually have a median survival of 30 months. And frankly, if that's recapitulated, this is a big deal. However, there's only 6 patients in our cohort, so we got ways to go. For the control curve, what we ended up doing is we picked out a set of patients who were age KPS matched, okay, and the recurrence matched. And what we saw here for that cohort is a survival of about 20 months or so, and that's typical of MGMT promoter methylated patients. For the unmethylated patients, we did see a survival benefit, but that's only about 3 months. So less to write home about. But this is something that's worthwhile pursuing, I believe, and we are actively working hard to recapitulate or to validate this data. So I'm going to show you now a couple cases that are illustrative. This is our first patient, okay? The patient presented in May. This was done in an outside hospital. They did a really nice job. I thought the resection was good. I don't think I would have done better. But the tumor came back within 4 months. Okay, so this now patient came to me. I thought I did a good job. Within, again, 4 months, the tumor came back again. This patient is now devastated, ready to call it quits, right? So with Gammatile coming available, knowing this is a super aggressive local resection, I mean, again, I thought I did a good job on this, right? And another surgeon did a good job. We implanted Gammatile. Now, this Gammatile did buy this patient 9 months of progression-free survival. Unfortunately, the patient tumor now recurred, but it recurred outside of the Gammatile range, right? To the point I was raising, if you don't have a good quarterback, the analogy being chemotherapy as the quarterback, you're not going to win the game, right? But we did buy time, and that time was meaningful to this patient. Many of you will ask me, hey, I've treated a patient with radiosurgery. What about Gammatile versus radiosurgery, right? So this is a natural experiment of sorts. We had a patient who had a right frontal tumor that I could resect and a left frontal tumor that in the motor strip that's puny, and I'm not going to touch it, right? Most of us will resect this one and not this one. So we resected this one, implanted it with a Gammatile, and then we treated the other one with SRS because we wanted to give it the best chance of control. And guess what happened? 4 months later, good control of the Gammatile resection area. The SRS area, not so much. Right? So in the natural experiment, we actually haven't sensed that this approach, resection followed by high dose radiation, is better than SRS. And frankly, we all know that, but I just thought this is interesting. Now, the Gammatile to me is a surgical extender. If you are doing a super radical resection, you're taking out the entire right frontal lobe, there's probably little value to Gammatile. But as you heard from Mike and from all the previous talks, when you do that, you're losing a lot of stuff we don't know about, right? So I don't typically do a super radical resection. The point is that the amount of resection matters because your tile, okay, is only an extender of your surgery. So this is a awake surgery. This is a third recurrence of a patient who's on Avastin, came to me, had no other options, and I ended up doing a surgery, but during an awake surgery, the patient lost its ability to speak, did all the usual maneuvers, we couldn't get it back, so we stopped. And then his speech got better after surgery. The problem here is there's significant tumor left anterior. In fact, extends beyond the range of the tile, which is shown in green. And that stuff just blew up. You can see it. 47 days after my surgery, the patient went palliative. I didn't help this patient. The extended resection matters. If you don't extend, if you leave significant tumor behind outside of the Gammatile range, we stand to reason that it's going to grow. And by the time of third recurrence, that's going to grow rapidly. However, tile is a good extender. Here's another craniotomy that I thought I did a pretty decent job, but I left some tumor behind. But fortunately, we put in a tile, and 30 months later, that remains controlled. Okay? It gives us a little bit of leverage. Okay. The tiles can be placed in multiple places. This is a patient who's a third recurrence. 2 tumors grew. We took out both tumors, putting tiles in both. Unfortunately, the tumor did go back. Again, it grew back outside of the tile region. No quarterback. Ultimately, we lost the game. We bought time. Sometimes it grows back. These tumors can resist 150 grades of radiation. This is a patient. This is a tumor. Initial resection. Came back, referred to me. I thought I did a decent job putting tiles, but the tumor grew back within a month. So there are tumors that are refractory to 150 grades of radiation. And we do need to do better in terms of systemic therapy. What about newly diagnosed glioblastoma? All right, why did I explore this? Here's a patient that, this is a 60-some-year-old gentleman who presented with 2 tumors. There's 1 tumor here, and there's something above here. Okay. We ended up taking the tumor out. This one I did an okay job, not so much. There's maybe some stuff left behind. Okay. Remember how we talked about tumor growth after resection? This patient was waiting for radiation. On the radiation planning scan, we saw this. Not only did the tumor grow back, both tumors got bigger. So based on the survival curve that I showed you at the very beginning of the talk, you know this is not a patient who's going to do well, right? So we decided to take both tumors out, okay? At that time, we were planning a newly diagnosed glioblastoma trial. The problem here is you don't want the Gammatile radiation to overlap the conventional radiation. So we had approved, we had an IRB approved to do the following, which is remove the tumor, put in tiles, let a month go by. So the tiles radiation is essentially down to about 5%, 10%, right? 3 half-lives. Each half-life is about 9 days. And then you start chemo radiation. So this patient had this. And we actually had pretty good control of this until about 280 days. I think 274 to be exact. And then the tumor came back. I honestly, I don't have a control. I don't have an identical patient where I could split into 2, right? But I honestly think that this patient, given this growth, would not have lived 274 days without repeat surgery and Gammatile. But I can't prove it. Here's another patient. Initial tumor, glioblastoma, outside neurosurgeon, did a really nice job. Pre-radiation scan, again, you see 70% of the tumor came back. It's almost as if they didn't do a surgery, right? Sometimes we don't see this because the radiation oncologists don't tell us about it. This is happening more often than you think. We did the resection, put in the tiles. This is how we show, so the radiation that's delivered after Gammatile has to be special. You have to block out where the radiation is already delivered to avoid toxicity. Okay, so this is to show that the radiation that's delivered is blocking out where the tile had already delivered radiation. This patient's still alive in today, almost a year and a half, and local control is perfect. I mean, this, I just saw the scan yesterday when I was taught. I realized I'm going to share this case. I wanted to give you an update. This is a patient still doing perfectly for a very, very aggressive tumor, right? So I do think there is a value in, oh, here it is. So I haven't put in the scan from yesterday, but this is at 9 months. As of yesterday, it is still under control. So this is the protocols for those of you who are interested in participating. We are, this is to, not to go into the details because I think I'm running short on time, but look at clinicaltrial.gov and just do a search on Gammatiles and glioblastoma, and you could read the details of the protocol. I hope that many of you will participate in this study. So what about brain metastasis? Like I said, well, one thing to highlight, brain metastasis will become more and more a problem for all of us. Why? Well, the population is growing. The older we are, the more likely we are to get cancer, sadly, for many of us to think about. The more you get cancer, the more likely you get brain metastasis. I'm convinced that the number of brain metastasis that we'll see will be exponentially increasing in the upcoming decade. Okay. We do know radiosurgery works quite well. And it's okay to do radiosurgery for most of the brain metastasis. But here are a couple things, a couple patients, scenarios to consider. Here's a patient who I treated. I did a supraorbital resection of this tumor, followed by radiosurgery. Patient did really well, went home the next day. Unfortunately, 9 months later, the tumor came back. Okay. It needs another surgery. This is big enough that I would not be comfortable treating with repeat radiation. So we treated, we removed this tumor, added Gammatiles. The patient's almost 9 months out now. Okay. Of the patients I've treated where the tumor came back after SRS and it treated with resection and Gammatile, I have not yet seen a failure, but still early days. Okay. There is a clinical trial that's initiated by Memorial Sloan Kettering, and we're working with them to make it a multi-institutional experience to use Gammatiles in the setting of SRS failure. So I do think this is a productive area to consider Gammatile placement. Glioblastoma could grow back quickly, so too can brain metastasis. This is a patient, unusual squamous cancer of the penis. I mean, I've never seen it. Had a tumor, was hemiplegic. One of my colleagues took it out, did a pretty good job. Okay, but it did a good job. I shouldn't say pretty good job. It did a good job. But the tumor, oh, I'm sorry. This is yet a different case. Sorry. Let me fast forward to the case I was going to talk about. This is the squamous cancer of the penis. My colleague did a really good job taking it out. While waiting for SRS, the patient came back to the emergency room with recurrent hemiplegia. MRI shows the tumor's grown back to about 70% of the original. So we took the tumor out, put in tiles. This patient actually died within kind of 4 months of presentation. The tumor is so aggressive. But I do wonder if we had put tiles in up front, could we have saved him the second surgery? This is a very interesting case I'm writing up right now, okay? This is a patient with lung cancer, but has a ALK fusion. This tumor with this fusion is exquisitely sensitive to a targeted therapy focusing on ALK. fusions. The problem is there's a rebound effect, and the oncologist is just dreadful of stopping the targeted therapy for more than a few days, because the rebound effect is genuine. So we decided that we stop the targeted therapy 2 days before. And what's really interesting, you'll see the tumor is actually responding to therapy. You see the tumor smaller. Okay. We ended up resecting this, putting the Gammatile, 6 months. And we resumed the targeted therapy 2 days after surgery. So this basically patients had targeted therapy, stopped for 2 days, and resumed therapy. He didn't have to stop for a gamma knife. He didn't have to stop for anything. The wound didn't break down. This patient remains well as of today. So tiles may be an opportunity for those of patients who benefit from targeted therapy, who the oncologists do not wish to stop therapy. This is a very good option. And of course, this is another clinical study I love for all of you to participate in. This is a study that's done by MD Anderson. The rationale is the following. We all know that radiosurgery works quite well. Okay. Across 5 randomized control studies, the local control at 1 year is about 70% across 5 studies. Okay, 70% is a pretty good number. But if you look carefully at the numbers presented, those are averages of small and big tumors. And in fact, if you look at the larger tumors, this is one of the randomized control studies that MD Anderson carried out. If the tumor is greater than 2.5 centimeters, the local control rate is like 50%. Okay. Now, realize what I just said to you. Tumors that fail gamma knife responds to resection plus Gammatile, suggesting that surgery plus Gammatile is better. Remember the patient I showed you, where you have tumor on one side, we treat it with gamma knife, and the other side treated with Gammatile, surgery plus Gammatile, and the second side's better. So with those case considerations, the company has sponsored a study. MD Anderson's taking the lead, and we're participating, of course, where tumors that are more than 2.5 centimeters are randomized to surgery plus SRT versus surgery plus Gammatile. Okay, and the primary endpoint will be local control. Given what I've seen to date, I believe this study has the potential to reshape how we treat brain metastasis. And I hope all of you will participate. So in this talk, what I've shared with you is sort of the historical context of why we were excited about brachytherapy, why this fell out of favor. And I will tell you, in my colleagues' radiation oncology department, there are people who favor brachytherapy, and there are people who just are outright convinced this doesn't work. Okay. But I do think the data needs to be reevaluated through the lens of modern clinical trial design. I talked to you a little bit about our data with recurrent glioblastoma. We're in the process of putting together a series that essentially recapitulate our earlier series through a multi-institutional experience. I talked to you about some rationales for newly diagnosed glioblastoma, as well as the clinical trial that I hope you'll participate. And then I share with you some of the scenarios in which brain metastasis or Gammatile should be a consideration for brain metastasis.